This session is about women, and the moderator is my colleague and co-instructor in our distance education course, Sierin Lim, who is at the School of Chemical and Biomedical Engineering at Nanyang Technological University in Singapore, another new APRU member. So let me tell you about Professor Lim. PhD is an associate professor of bioengineering at the School of Chemical and Biomedical Engineering at NTU, Nanyang Technological University. She serves as Associate Dean, Global Partnerships at the NTU Graduate College and the Co-Deputy Executive Director of the NTU Institute for Health Technologies. Her bioengineered and applied nanomaterials laboratory, BEAMS lab, focuses on the design and engineering of hybrid nano microscale devices from biological parts by utilizing protein engineering as a tool for applications in medicine, energy, cosmetics, and food. And I would encourage you to look at her bio in the program. She founded the Biomedical Engineering Society in Singapore Student Chapter in 2009. She's received the L'Oreal UNESCO Singapore for Women in Science National Fellowship. And in 2020, the inaugural Singapore 100 Women in Tech list. So none of that is my expertise. So I am so glad that you are here to moderate this session. Thank you so much for joining.
Thank you, Melissa, for inviting. And this is really a new adventure for me because, as she had mentioned, I am not trained in global health, but I have an innate interest in contributing. So thank you for the opportunity. So really an exciting panel coming up. Welcome to the APRU Global Health Conference Panel 3. And this conference is organized by Fudan University and the APRU Global Health Program. I am Sierin Lim from Nanyang Technological University. Please share the conference with a hashtag at APRU1997 at various news media, social media outlets, and a hashtag APRUGH2020 and APRU. And the same format for the conference in the past panels. We have 30-minute presentation for each presenter with 10-minute Q&A after the presentations. We encourage all participants to raise the questions via the Q&A function during the presentations, and I'll collate the questions and present them to the panel members at the end of the presentations. We have 3 exciting speakers for the session: Dr. Megan Boren from University of Melbourne, Professor Chan Su from Fudan University, and Annie Kuo from University of Washington. And I'm going to introduce our first speaker, Dr. Megan Boren. She's a Senior Research Fellow in the Gender and Women's Health Unit, Center for Health Equity at University of Melbourne in Australia. She holds an Australian Research Council Discovery Early Career Research Award and Dame Kate Campbell Fellowship. She has been leading many efforts in improving women's experience with pregnancy and childbirth care, and works primarily with groups who are disadvantaged by systems of power. Dr. Boren has a particular interest in using innovative qualitative research methods to bring community and health worker voices to the public health guideline development process. She's also an editor with Cochrane, section editor of BMC Reproductive Health, and member of the Great Cirqual Steering Committee. She has also been working at she had also worked at the Department of Reproductive Health and research at the World Health Organization, Geneva, and Population Services International at Washington, DC. Over to you, Dr. Megan Boren.
Thanks, everyone. And let me just get my screen shared here. I hope you can see that okay. Great, thanks very much for the introduction, and I'm very happy to be speaking to you today. I'm speaking to you today from the traditional lands of the Wurundjeri people of the Kulin Nation, and I pay my respects to their elders, past, present, and emerging, and acknowledge that sovereignty over these lands was never ceded. My name is Megan Bourne, and just as a bit of background, I am a social scientist by training and primarily working in women's health and reproductive health with a focus on pregnancy and childbirth. Today, I'm going to talk to you about bringing women's voices into maternity care in the SDG era, which is one of the sort of key areas that I've been working on for the past few years. So there's been some shifting global priorities for maternal health in the SDG era. During the Millennium Development Goals up until 2015, there was a real focus on improving access to healthcare services, as well as on reducing avoidable mortality and morbidity. And a lot of these issues, they still remain important today, but there's a bit of a shift in the global priorities for maternal health towards improving quality of care. And so basically, this is reflecting our knowledge that it's not enough to just get a woman to a health facility to receive care, but what happens to her once she gets to that setting is really important for many reasons that we'll go through today. And so this is a sort of sphere that I'm working in with my work on improving quality of care. And this is all couched in the vision for quality of care. So this is developed by the World Health Organization and recognizing as a guiding principle that quality of care for women and newborns needs to be safe, effective, timely, and efficient. And I think these are all very familiar words to those of you who are working in public health. But the two that I want to focus on today are the importance of this care being both equitable and person-centered. And so where this comes in terms of how do we think about quality of care in a framework is that we think about this in terms of improving experiences of care. So making sure that the experiences that people have during their care encounters are sort of underpinned by having effective communication with their healthcare providers, ensuring that they're respected and their dignity is preserved, and ensuring that they have the emotional support that they need to have agency over their own bodies and over their own experiences. And sort of this positioning of making sure that care is both equitable and person-centered can sometimes make people feel a bit uncomfortable. And it's a bit of a new sort of terminology to use in terms of quality, where historically it's mostly focused on making sure that care is provided using evidence-based practices and actionable information systems. And so I'll talk you through a bit about why this is so important. So this is sort of all also couched in making sure that all people have a positive birth experience. And these birth experiences basically are meaning that we're making sure that people have their social cultural beliefs and expectations maintained, making sure that they're not only giving birth to a healthy baby, but making sure that they have a safe environment in which to give birth. So this means that we make sure that there's continuity of both practical support as well as emotional support, for instance, from a birth companion, and in the presence of healthcare staff who are kind as well as technically competent. And this is based on the sort of recognition that birth is, of course, a really special event in people's lives, and that for a woman giving birth, birth is a real personal achievement, and that we can and should make sure that we take efforts to make sure that women can control their reproductive autonomy, make sure that they're involved in decision-making, even when there might be a need for medical interventions. And this positive birth experience language is language that has now sort of reached the highest levels of maternal health. So over on the right, I have a photo of the cover of the WHO most recent guidelines for childbirth care. And you'll see that the positive childbirth experience is really centered within this guideline. And this is a really important shift in sort of how we think about maternity care and making sure that positive birth experiences are given the same level of influence as the clinical aspects of care. So why do positive birth experiences matter? I think that they matter for three key reasons. So they matter because of human rights and because of women's rights. And this is particularly centered around the right to health, the right to have health care provided with freedom from discrimination, as well as the right for women and their families to be treated with respect and dignity when they're accessing healthcare services. Positive birth experiences also matter because of quality of care. So as I mentioned, using the WHO framework, we see that the The experiences of care are equally important as clinical care that is provided, and they should be treated as such. It's also really important that when we consider quality of care, we consider person-centered outcomes. And person-centered outcomes might be related to people's experiences of care, or they might be related to their satisfaction with the care that they've received. And these are equally important to measure as, for example, other health outcomes or healthcare utilization. And lastly, positive birth experiences really matter because they can have a really profound impact on care seeking. And we know from previous research that when people do not have positive birth experiences, they may be disincentivized to seek healthcare in future pregnancies, in future child healthcare, or in future care experiences for themselves. So now I'm going to tell you a bit of a research story. It's one of my favorite research stories. Prior to moving to Australia, I worked at WHO, where I led the multi-country study on how women are treated during facility-based childbirth. And basically, the study started back in 2013, so now I'm very much aging myself, where we had a technical consultation to develop a global research agenda of what does it look like to improve women's experiences of maternity care. This led to the first ever WHO position statement on this topic, titled The Prevention and Elimination of Disrespect and Abuse During Facility-Based Childbirth, where we laid out what the research agenda was. And this statement was really important to us because it was developed alongside colleagues who were working in advocacy, in civil society, in research, programming, and governments. So it was really a collective call to action to do something to improve women's experiences of maternity care. One of the main outputs of our global research agenda was to develop and validate measurement tools to measure how women are treated during facility-based childbirth. And so this study ran from 2014 till 2019, and it consisted of three main components that I'll walk you through some of the key results in the next couple minutes. The first was to conduct a mixed method systematic review to look at all of the global literature related to negative experiences of maternity care. And so here we were aiming to develop a typology of what constituted mistreatment during childbirth in order to have a better understanding about how we might go about measuring it. Next, we conducted a primary qualitative formative research study in 4 countries that you'll see on that map below. So in Guinea, Ghana, and Nigeria in West Africa, as well as in Myanmar in Southeast Asia. And in this formative phase, we conducted interviews and focus groups with both women and with healthcare providers, including midwives and doctors and healthcare managers. And here we're really looking at sort of diving deep into women's experiences of care and understanding some of the different social norms and contexts that shape these experiences. And lastly, we conducted a measurement study in order to measure how prevalent these different types of mistreatment are. So in the first instance in our systematic review, we developed a typology of mistreatment that sort of fell into 6 main categories. The first is physical abuse. So this included things like slapping, hitting, and pinching a woman during childbirth. And typically this is happening sort of at the hands of healthcare providers. The next category was looking at verbal abuse, and this included things like harsh language towards the woman, threatening her and her baby with poor outcomes if she doesn't comply with the health worker's instructions, or blaming her for negative health outcomes that might occur during her birth. Next, there are also many instances of stigma and discrimination, and sort of what factors women were being discriminated against depended on the context. But they included things like younger adolescent pregnancies based on a woman's race, ethnicity, or religion, or things that seem to be sort of gender discrimination in general when, for example, the healthcare provider was a man. We also found that there was a failure to meet professional standards of care. And this is typically centering around things like not having informed consent before a procedure or an examination, or breaches of confidentiality of private health information of women. In some cases, it also led to extreme cases of neglect, such that a woman might give birth in a health facility, but then not have any health worker at all to support her while giving birth. We found that it was quite common for there to be poor rapport between women and healthcare providers. And this is primarily centering around things like ineffective communication so that women didn't understand what was happening to their bodies, or things like lack of supportive care and the absence of labor companionship, or loss of autonomy from the woman's perspective over what was going on to her body during birth. We found that in many instances, there were health systems conditions and constraints that contributed to all of these different factors related to mistreatment, but that in some cases, women might actually experience these health system conditions and constraints as mistreatment in and of themselves. And this included things like having a negative facility culture and the lack of resources and policies to promote women's experiences. So these are our main findings from our systematic review. In the next instance, we conducted the qualitative study. So this was in-depth interviews and focus groups with women, midwives, doctors, and health managers across 4 countries. I'd love to share all of our results with you today, but we'd probably be here all day. So I'll just share with you some of our key findings from Nigeria. So we found that physical and verbal abuse was widespread, and it was often acknowledged by both women and healthcare providers. We found that women were slapped and beaten in an effort to encourage them to have strength and to open up and deliver well. So it was used as a way to sort of motivate women to give birth. We found in some instances, women were physically restrained or tied down to the bed while they were in labor. And this was in an effort to sort of control their movements and make sure that they weren't acting out. We found really commonly that there were very judgmental comments made about a woman's sexual behaviors and her sexual history. And so, for instance, this would be comments from healthcare providers that you were having a lot of fun while you were having sex with this man, so don't cry out to me now in pain. And these judgmental comments really made women feel very, very poorly about their birth experiences. We also had women saying that they felt that they were being insulted, like they weren't human beings. And in some cases that women were avoiding the hospital altogether and giving birth at home because they didn't want to face the poor treatment that they would have from healthcare providers. In our next instance, we took the findings from our systematic review and from our qualitative research to develop 2 tools that we use to measure mistreatment across these 4 countries, Ghana, Guinea, Nigeria, and Myanmar. So we developed 2 tools. One was a labor observation, and this was to be conducted with women and in a one-to-one basis with an observer and a woman. And the other is the survey with women that was conducted in the community up to 8 weeks postpartum. And I'll walk you through some of these results from the community survey. So in our survey, we had over 2,600 women across these 4 countries, and we had some pretty shocking results that I'll share here. We found that more than 1/3 of women experienced physical abuse, verbal abuse, or discrimination. About half of women did not consent to vaginal exams before they were conducted. About 16% of women felt that they were ignored or that their presence was a nuisance. And about 5% of women or their babies were detained in the health facility because they weren't able to pay the bills. So pretty shocking results that were fairly consistent across countries. We also found that there were huge inequities in women's experiences of mistreatment. And in this case, we found that younger women were almost twice as likely as older women to experience physical abuse, and younger women with no education were 3.5 times as likely. So where do we go from here? Well, the key takeaway from this work is that we don't know what we don't measure. So if we don't measure women's experiences, then we don't know how we can act to improve them. And so because of this, we know that women's experiences of care can and should be integrated into maternal health programming, research, monitoring, and evaluation. We also need to make sure that we make a big effort to improve maternal health, accounting for complex social norms related to gender, racial, and other power dynamics that occur in society and then are reflected on the maternity care. We know that addressing these inequalities and promoting respectful care for all women is really crucial to improve equity in maternal health. And lastly, and perhaps most importantly, women in communities and their families really know what's important to them. And we must engage with them using participatory approaches to find out what the problems are, what's valued by them, and what we can do to improve them. So thanks very much. And I will pass back over to the next speaker. And please do feel free to get in touch or pop questions in the chat.
Thank you, Megan, for a very nice and comprehensive review and work on maternal care in various parts of the world. And we are now on to the next speaker, Dr. Qian Su, who is a professor of the Department of Maternal, Child, and Adolescent Health at the School of Public Health and the founding director of Global Health Institute at Fudan University in Shanghai. She has also serves as the chair-elect of the Women's Healthcare Branch and vice chair of Global Health Branch in Chinese Preventive Medicine Association. She is the member of the Scientific and Technical Advisory Group of the Department of Reproductive Health and Research in World Health Organization and the WHO Maternal and Perinatal Health Executive Guideline Development Group. Her projects have been funded by various entities, including UNICEF, UNFPA, the EU, and US NIH, as well as the UK DFID. She has worked in the field of maternal, child, and reproductive health for more than 30 years. And she was also the chair of the MCH department and deputy dean of the School of Public Health at Fudan University. Please welcome Dr. Chan Su.
Thanks to the conference organizer to invite me here to share my discussion on the topic. Today, I will through two case studies to discuss about quality of care and women's health, lessons from developing countries. This is my outline. I will follow this, discuss these three questions. So what is the core of quality healthcare which women have the right to access? Everyone, including women, have the right to achieve the highest attainable standard of health, including sexual and reproductive health. Sustainable Development Goal 3.8 said achieve the universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicine and vaccines for all. These statements are the international consensus. So what is the quality healthcare? Quality healthcare can be defined in many ways, but there is growing acknowledgement, according to WHO, that quality health services should be effective, safe, and people-centered, which our previous speakers already mentioned that. So what's the current status of quality care service in developing countries? Today, I will share with you two case studies which our group involved. First one is in Malawi. There is a highly significant maternal mortality ratio, 439 per 100,000 live births in 2015 in Malawi, and lagged far behind MDG 5A target of their countries, which is 155 per 100,000 in the 2015. The other hand, the increased hospital delivery rate, 90% in 2015 in Malawi, seems does not match with the reduction for maternal deaths. So above situation raises us concern about the quality of care provided by skilled attendants to pregnant women. With above concerns, a Malawi colleague who studied in Fudan University did a census of quality maternal care in her working area, Mazimba South, Malawi, in 2018. Here, I selected some results for today's discussion. Table 1 showed that some effective services were unable to be delivered to women due to the availability of resources. You can see that out of 31 health facilities, near 23% can provide a hemoglobin test, and 39% can provide a urine protein test. But these two tests are listed as the essential lab test service for focused antenatal care. Blood pressure machine and a thermometer are the essential equipment for maternity care, but more than 30% of the health facility don't have the functioning one. During the exit interview after ANC services, women reported less service received related to above service items, such as hemoglobin test and urine protein test, comparing to those services with high percentage of equipment or drug availability, such as fetal health monitoring and malaria prevention. Table 2 describes the referral situation of health facilities there. Out of 31 health facilities, near 68% were able to refer women within 2 hours to up-level health facilities, but only 23% provided a referral accompaniment by a skilled nurse. 90% were able to communicate with the up-level health facility using their personal mobile phone, but only 16 had access to ambulance on the spot. This raised up potential risk for emergency care. Table 3 is about provider-client relationships measured through exit interview. Under effective communication, only 42% of the women reported that the health providers introduced themselves before providing care to them. Only 37% of the women were able to answer questions about their care during antenatal care. On respect and preservation of privacy, only 51% of them had the health providers asking consent before procedures. From above results, we can see that lack of essential equipment influenced the women to receive quality antenatal care services, even in 218. Inadequate referral preparedness may influence women to access timely to emergency services. Women's experience of care may be influenced by the provision of care women received from the health providers. So this is the situation in Malawi now. Now let's move on to the second case, which I involved, which is the women's experience of childbirth in Shanghai. More recently, the WHO recognized the needs for the positive childbirth experience, which corresponds to the new global strategy for women's, children's, and adolescents' health. With an increase in emphasis on women-centered outcomes in clinical decision-making, women's experience of episiotomy during childbirth is highly relevant. A Cochrane review we did in 2017 pointed out that trials inadequately considered women's preference, views on the procedures, or the outcomes that are important to them. So we did a semi-structured in-depth interviews with women after episiotomy and using semantic analysis in Chinese. Emerging themes were debated in English to finalize interpretations. Four themes emerged from 30 interviews. Theme 1, women views the procedures very considerably. One woman said, I used to wonder that episiotomy is, and only came to know exactly what it is after childbirth. At that time, when I was cut, I know it. oh, this is episiotomy. At that time, I thought, oh my God, they will certainly cut my vulva. The vulva will be ugly and its function will be affected. It sounds scary. Another respondent said, I think it is necessary to do episiotomy when it can accelerate the progress of labor. But if the baby can be delivered smoothly, episiotomy should be avoided. After all, it is still a surgical procedure. Theme 2, pain interferes with women's daily life for weeks. It may restrict the posture and movement. Women have obvious difficulties in breastfeeding and defecation. Theme 3, long-term anxiety is a consequence for some women, described as psychological shadow. Women mentioned the uneven or rough skin of perinatal wonder and painful intercourse, which affected the enjoyment of sexual life. Several multiparous women who experienced episiotomy twice reported that they need a longer time to recover from it. Theme 4, society norms assume women will not complain. Family members think women's pain from childbirth is normal and endurable. Too many complaints incur criticism. Indeed, these society norms about tolerating pain also manifest in the way healthcare was provided. So this study clearly showed that women were inadequately informed about episiotomy, but experienced the consequences of the procedure, including pain and interference with daily life. These were compounded by social norms that expect them not to complain and longer-term anxiety about the physical and psychological effects on them as women. People-centered services were inadequate in the procedure and the nursing of episiotomy. Overuse medical procedures during childbirth may cause adverse consequences to women and influence their later life quality. So my conclusions to the above two cases, no matter in Malawi or in China, issues related to quality of maternal care still existed in different ways. Less access to effective and safe care services is the one issue, maybe we can call too little. Overuse medical procedure is the another issue, too much. People-centered care is inadequate in developing countries. To realize the benefits of quality health care, health services must also be timely, equitable, integrated, and efficient. That's all. Thank you very much.
Thank you very much, Professor Chuan. We are now going to introduce the third speaker of the session, Ms. Annie Kuo, who is the Director of Marketing Communications for the Department of Obstetrics and Gynecology at University of Washington School of Medicine. She's an ambassador for Resolve, the National Infertility Association USA, advancing public awareness and education about infertility as a disease, particularly in her capacity as an Asian American woman to address cultural and societal stigmas. Her personal experiences have really pushed her forward to advocate for women's fertility. She believes in the power of narrative to create social impact, both in the general public and among communities of color. Annie's story has been documented by NBC News, Mochi Magazine, Huffington Post, and a few other ones, including some books. In addition to her work in women's health, Annie also serves on the Men's Health Council at the UW Medicine. She dedicates her talk to her late husband, Victor Kuo, who traveled often to Greater China as lead researcher of the Global Chinese Philanthropy Initiative. Ms. Kuo, please.
Hi, everyone. Let's see here. Just going to share my screen. Okay. It's so great to join you from Seattle, Washington. Thank you to Melissa Withers at USC and the conference committee for inviting me to share my lived experiences about infertility with this audience. I was thrilled last night to see the poll results that about 3/4 of the audience are students, which is absolutely the ideal demographic for this talk, because I hope that this information will be helpful for you or someone that you know to one day build a family. Okay, let's talk about sex. We're all grown-ups here. I think most of us know at least clinically how to get the job done. But maybe culturally and socially around the Pacific Rim, you'd agree that there's not a lot of public talking about sex, even at home. Judging from the 1.4 million people in Greater China, sex is happening. But what's not happening so much is this talk about fertility and reproduction. Perhaps that's due to conservative social values or what is just socially acceptable or not acceptable to talk about openly. Okay, well, we all know that Asia is, just a moment. We all know that Asia is huge. It's composed of 48 countries. So for the purpose of this talk, I'm going to focus on the residents and immigrants from around the Pacific Rim. And I am dedicating this talk to my late husband, Victor Kuo, who passed away in June from heart disease at age 49. He traveled often to Greater China for work, and I think he'd be very proud because we were both dedicated to the Asian Pacific community. So this one is for Victor. Sex talk is just taboo. Whenever I've broached the topic of sex with my parents in the past, they've been embarrassed, annoyed, or mad. When I first asked my mom how babies were made, she said, "When you sleep with a boy." So from that point on, I made my younger brother sleep upright in a rocking chair whenever we had sleepovers in my room. A friend told me that her Chinese grandma said babies come from armpits. And for years, she thought it wasn't armpits, but it was from the butt. She learned about sex from romance novels. I learned how babies were made through illustrations in the classic book, Our Bodies, Ourselves. I remember being puzzled about the dashes around the private parts in the pictures and asking my mom just what exactly was going on there. And when I got my period for the first time, I remember my mother's reaction wasn't exactly thrilled. She just said, "Okay, now you can get pregnant." And later I realized that she was told the very same thing when she got her period as a child. This is a screenshot of a Twitter account that I made for my first pregnancy, which was short-lived, just 14 weeks. At 9 weeks, I was diagnosed with a blighted ovum, and then I chose to miscarry naturally, which happened 5 weeks later on Christmas Eve. So if sex talk is off limits, especially between generations, imagine discussions about the inability to conceive or maintain pregnancy. Those are even less likely. So if Asians are having trouble, it's such an unexpected situation, so foreign that the culture as a whole just doesn't have a script for what to say or do. The morning after my miscarriage, I told my mom in just one breath that I'd both been pregnant and lost it. And she said, "What's wrong with you? Nothing like that ever happened to me." And though it stunned me into silence in the moment, I realized later it was just cultural. My mom had not grown up talking about infertility. She learned about sex by watching animals mate. There was no formal sex education in Thailand. And for that reason, she didn't tell me until I was 38 that she had early menopause. If fertility was never discussed, then medical treatment was certainly an anomaly. The first thing my mom asked when I told her I was thinking about freezing my eggs was whether a future child might have birth defects. So people of Pacific Rim descent are 10% more likely than whites to die of cancer, 80% more likely to die from liver cancer, twice as likely to die from stomach cancer, 15 times more likely to suffer from tuberculosis, and 3 to 4.5 times more likely to suffer from hepatitis A or B. Clearly, there are conditions we're more prone to developing because of our genetic makeup and cellular constitution. In the US, people of Asian descent are often lumped together to reinforce the positive but detrimental stereotype of the model minority myth. And this can extend to the health arena as well. My husband had a PhD from Stanford and swam faithfully every morning for 6 years. But for all of those outward appearances, sometimes there's something else going on inwardly. Unbeknownst to me, Victor struggled with clinical depression, but he declined treatment, which in retrospect seemed to interfere with his compliance to diabetes management. Could stigma, denial, and/or ignorance to certain health conditions be preventing our pursuit of care? And could there possibly be an implicit bias on the part of Western or Asian healthcare providers in lumping Asians together in medical treatment? The WHO calls infertility a disease, and it's an equal opportunity disease that doesn't discriminate on race or class status. And yet Asians have certain predispositions to conditions that are unlike other races. Asian men and women are less likely to consent to be contacted for fertility research, and they generally seem less informed about fertility issues. From a survey, less than half of Asian people seem to know that the chances of getting pregnant decline with age, and they're less likely to suspect a male factor of infertility. Infertility affects 1 in 8 couples, or 1 in 6 women if we include unmarried women who are trying to get pregnant, but unable to conceive after a year of intercourse under the age of 35, or within 6 months if over 35, and that's the definition of infertility. Celebrities like Chrissy Teigen, who is a half-time model, author, and TV host here in the US, married to R&B and soul singer John Legend, has shared that they went through IVF to build their family, and that she also experienced postpartum depression. I'm very grateful for people like Chrissy who are open about their experiences, because it opens the way for people to feel less alone and also to share what they're going through with loved ones. Earlier this month, Chrissy and John Legend also shared the devastating news of losing their 3rd child, Jack, in the hospital shortly after he was born. People in Asian communities often are very family oriented. So reproduction, expanding the family line, is expected and anticipated. A generation gap and lack of understanding can exist unless elders have also gone through an infertility experience or procedure. In childbearing, a lot of the responsibility is placed on women. In the movies The Last Emperor and Joylet Club, when the husbands repeatedly refused to engage with their wives on the marital bed, the women were the ones blamed by the extended family for the failure to produce heirs, when actually one husband had barely reached puberty and the other one was gay. After my miscarriage, several Asian elders asked me what I did to cause it. Did I put my arms over my head? Did I carry heavy groceries or exercise too much? Was I not praying or going to church enough? In Asian immigrant families, our parents want us to have a good life, and due to their sacrifices, we often don't want them to worry. So we just take on hard stuff ourselves and quietly. The social pressure and embarrassment can be compounded by the response of well-meaning but ignorant friends and family who may offer unhelpful suggestions and comments. A quick disclaimer before we get to the next slide on health inequities and social justice. There are many ways to build a family. Medical treatment is one if people are experiencing problems, but there's also foster care adoption in the US, where more than 1 in 5 Asian American women of childbearing age, that is up to the age of 44, are uninsured. When I advocate in Washington, DC for family building legislation to support Americans who have an infertility diagnosis, we also support lobbying for foster care and adoption. Asian women experience a fertility decline about 3 years earlier than white women, and we also experience higher rates of conditions like endometriosis, PCOS, and systemic lupus that affect conception, or vaginismus, which can affect intercourse. There are also certain environmental factors that Asians are exposed to, such as through fish, more exposure to methylmercury, or higher rates of vitamin D deficiency. A 2000 study published in the Journal of Fertility and Sterility revealed that Asians who undergo assisted reproductive technologies like IUI and IVF actually have 33% lower pregnancy rates despite similar baseline conditions, and even with optimal conditions like lower than average BMI, good embryo quality, healthier diets, which you would assume would translate to better fertility outcomes. East Asian women need a longer time to stimulate their ovaries to produce more eggs, and yet fewer eggs are retrieved, and there are fewer surplus 5-day embryos to freeze for future transfers. But the causes of these are not really well substantiated in the research. There's also poor outcomes from fresh embryo transfers, but not frozen embryos using using donor eggs. And this seems to point toward negative effects on the uterine environment experienced primarily by this demographic. A study utilizing the SART database, drawing from about 26,000 Caucasian and 1,500 Asian patients, demonstrated a decreased cumulative pregnancy and live birth rate among Asian women undergoing IVF compared to Caucasian women. And so this is something just to kind of keep an eye on. I think there's a lot more research that can be done in this area. Asian men, by the way, they may also have a harder time culturally and socially accepting a male factor issue that needs treatment. Recruiting Asian egg and sperm donors can be challenging because of cultural stigmas. To many Asians, donating sperm or eggs may seem like more of a business transaction than a humanitarian one. Even worse, gamete donation may be viewed interculturally as selling one's bloodline for profit, an action frowned upon since the bloodline is sacred in many Asian cultures. So much so that only until recent years have domestic adoptions in Korea become more socially acceptable. Asians are not as aware of the opportunity to donate eggs or sperm or the need to support one another in that way. So many fertility clinics recruit from overseas or from other regions where there's a larger Asian demographic. Okay, this is the ticking time bomb part. More than 40% of Asian patients delayed meeting with a physician or fertility specialist at least 2 years after facing problems. And this can influence their chances for success with assisted reproductive technology. Precious time is often wasted because of denial or distrust of medical professionals. Like many Asians, I hesitated to consult a doctor even a year after a miscarriage and not getting pregnant again. If it were not for the encouragement of a white friend who'd had a child by IVF after secondary infertility, I may have delayed seeing a doctor even further. But it turns out that the doctor was able to support the continuation of my second pregnancy with simple medication. And I may not have my daughter if it were not for those 2 visits. Accepting the possibility of a problem is the first step towards solving it. The warning here for us is that an Asian couple struggling to conceive should consult a fertility specialist sooner than later, and it may take longer for them to be successful through fertility treatment. If they pursue family building through other means such as adoption, which is not a quick or inexpensive process. They have more time to start on that path. Finally, call to action. Talking about it may just be the thing that helps the most. Social media is a great platform to reach many people. The more we talk about infertility, the less stigma and shame there will be around it. And by encouraging open conversation with friends and family, people might be encouraged to seek help sooner. I've seen more and more people on my Facebook feed talking openly about their struggles with infertility, and you wouldn't believe the number of people who open up about their own experiences in the comment section. It helps people feel that they're not alone, that people in their own social circle have struggled as well. I also think empowering people by equipping them with knowledge can help. It's important to share knowledge and provide resources that everyone can understand, not just scientists and doctors. Here are a couple documentaries I highly recommend. I'm in the one, Don't Talk About the Baby. One More Shot is excellent as well. And you're welcome to peruse my website, which has more writings on infertility in the Asian community. The key to successful family building outcomes for healthcare providers lies in customizing patient care. So I hope that the clinicians out there will consider perhaps doing some more research in this area. And for those who are in graduate school, I hope that perhaps I've planted a seed for your consideration. And the next slide is just my contact information. Thank you so much. Thank you for listening.
Okay, thank you, Ms. Ko, for a very personal sharing of these journey. And I hope all of us can learn a little bit about from your story. So we have a few questions that will be directed to the panelists. First is from Ms. Joy Adeoti to Dr. Boren. She has asked whether women face abuse and maltreatment during labor. So what can be done to reduce this? And perhaps also another question here, whether with regard of painless childbirth, would it be actually a good and effective mean to reduce mortality? And what are the main difficulties for the implementation?
Great, thank you very much for the questions, and also thank you to the other panelists for their really great presentations. It's really lovely to hear the sort of unified theme throughout our work about the importance of bringing people's perspectives into healthcare. Thanks so much for these questions, and I agree these are very well connected. So we know that because of the causes of how women are poorly treated during labor and birth are multifactorial, it's really unlikely that there's going to be a single intervention that will just improve all women's experiences of care. And in fact, oversimplifying it in that way might actually lead to worse care for the people who are most disadvantaged. I think there's a couple of areas that we can focus our efforts on trying to improve women's experiences of maternity care. The first is on improving the birth environment and making sure that the structure of the labor and delivery ward is actually more focused on the needs of women and their families rather than just focusing on what's convenient for healthcare providers. The second one I wanted to focus on is also looking at making sure that we're supporting and mentoring healthcare providers in a supportive way that's promoting growth. So we know that healthcare workers are people too, and they struggle with their own challenges and stressors in their work environments. And we need to make sure that they're well supported to make sure that they can then provide care in a way that is a positive experience for women. There's many more other ideas that I have, but I also just wanted to focus on the question about pain relief. I think that's a really great point. But one of the important things about pain relief is that women have really different perspectives on whether they would like to have pain relief during labor and what type of pain relief that they would like to have if they would like to have it. And so it's really important here to focus on what women's choices are and to make sure that women are having these discussions with their healthcare providers, as well as highlighting that pain relief isn't just about medication, that it can also be about massage, gentle touch, warm baths, and things like this that can help to reduce pain without introducing drugs. So thanks very much for those questions.
Okay, thanks, Megan. We have also a question for Professor Tran. Did the result vary by social factors such as the woman's educational qualification in your studies?
Yes, actually, for the second study, we already published. For the first study is the PhD thesis, which my Malawi colleague did. So we actually had the a multi-regression model to control the socio-economic factors for the personal. But today, what I present is just what I like to show the use very simple data to show the issues about the current situation in Malawi. Even in the 2018, we still have some essential services unable to be delivered to women because of the availability of the resources. So I think this needs the government commitment, and also all stakeholders work together to dealing with these kind of issues. So we can have the way towards SDGs. Thank you.
Thank you, Professor Chen. A question specifically for Ms. Kuo. Are there any ethical issues or studies regarding the use of IVF and other types of medical treatment instead of adopting or fostering a child? And also perhaps here, how can you educate couples about assisted fertility methods like IVF and the religious cultures and education to the men itself in terms of that they are also part of the whole process?
Mm-hmm. I would respond to the first question about ethical issues by saying that it's largely an individual choice. However, in personal context, that often include religion. Sometimes religious systems have their own ethical views on the use of assisted reproductive technology. I hosted monthly support groups for over 4 years in the Seattle area, and we had many Catholic infertility patients really struggle with this choice to pursue fertility treatment to have a genetically related or biological child. So I would say there's probably not a universal ethical issue except in the Catholic Church or perhaps, personal spheres. The second question that you asked is about education and wrapping in.
Right, education instead of adopting, so education in fertility, in the sex education program, as well as the adoptions, and why people wouldn't just do adoption rather than having to go through IVF.
Okay, is this the question? Is it important to talk about infertility in educational programs, and how could we integrate this issue? Yeah, I think that it would be fantastic for, like in high school, when I did a sex ed class in the US, they just had us, carry around an egg with a partner for a week and just see what it might be like to take care of a baby. But they don't often, it's very ironic. For example, when someone with infertility gets that diagnosis, they spent probably up to that point, 5 to 10 to 15 years trying not to get pregnant. They never think about what it's going to be like to not have that choice. And so I think it would be very instructive and effective to at least plant the seed that 1 in 8 couples actually face infertility, right? You want to have that problem of carrying the egg around and not wanting to drop it, as a metaphor for taking care of a child. But a lot of times, the emphasis in high school is on prevention.
Okay, thanks for the panel. I have just one more question that probably span all, and in the midst of this pandemic, how would you see the effect of COVID-19 on women's fertility, health, and etc.? Yes, maybe a little bit of wrap-up comments from each of the panelists. Ms. Boren, would you like to start?
Sure, thank you. I think this is a great and very timely question. So I might just focus on the aspects of how COVID might affect women's experiences of maternity care. And I think there's a few key ways. Sort of early in the pandemic, what we saw was that one of the first things that were eroded in maternity care were women's rights. And this included things like the right for women to have someone, whether their partner or a family member or a friend, to support them during labor and childbirth. And this is one of the key things that is still really quite difficult to reintroduce in many different contexts. And sort of extending on beyond those other social factors is that, for instance, in Australia, we are sort of on day one of a post 102-day lockdown in which we weren't allowed to see family members and friends to have any social contact. And so the context for new moms in that is really quite difficult in things of maternal child health, community-based visits, breastfeeding support if there's any sort of challenges, and also just having hugs and chats with family and friends who have been in sort of similar circumstances. So the social impacts of COVID on maternal health are really quite substantial and something that we need to work to do better in the sort of expanded response to COVID.
Okay, Professor Chen, please, yes.
Okay, in China, actually, we during the COVID-19, we reorganized the MCH care delivery system, especially to convenient women to access the service. So many hospitals, they start from they started their social media website, and also, you know, keep those like women would like to have more contact during the pregnancy. So through social media, it's really helpful. And also, if some women have like fever or what, then, you know, the service area will be reorganized so can avoid the contamination. So, and also the government also issued the like regulatory document to really deliver the effective service to women during COVID-19. Thank you.
Thanks. Ms. Kuo?
Great question, very timely. Over the past 6-7 months, we've seen through the Department of OBGYN changes in protocols for labor and delivery, also in treating patients across the women's healthcare spectrum and for receiving fertility care or family planning. And so we developed some guidelines to assist folks who need to come in and need to be reminded that you should come in to get your birth control. You should come in for cancer care. At the time, it was a lot more strict when we didn't know so much, but I think in terms of fertility care, when people can do so safely, the doors have been opened. And I know that was a big thing for a lot of fertility patients because, the time is clicking. A month is forever for a lot of fertility patients who just need every chance to get closer to having their baby. And so that was something that we saw was affecting our fertility practice, but has since relaxed a little bit more, much to the relief of many folks who are trying to build their families sooner than later through the pandemic.
Right. Okay, so thank you very much again for all the panelists. I think we all have something to take home. And with all the sharing and then all the studies that has been done, I think we can definitely improve maternal and childcare health and care moving forward. And there's definitely a lot to do, and we still we can do this together.